I'm good.
Good morning, everyone. We will get started here in just a moment. We're just have a couple more that are still showing they're connecting, and we will kick off the South Dakota Project Firstline office hours for the month of June. All right, we'll go ahead and get started here. As I said, this is South Dakota Project Firstline office hours, for June 2024. For those of you that are not familiar with our office hours format, this is an opportunity where some infection control education will be shared each month. There is a different topic. From there, we will provide a little bit of education and also allow an opportunity for any questions, answers, or conversation amongst the attendees in the office hours. So Rebecca, would you like to go to the next slide? South Dakota Project Firstline is an initiative that was brought through the CDC. The South Dakota Department of Health is the contract holder with the CDC, and we at South Dakota Foundation for Medical Care work through the contract to provide the initiative South Dakota Project Firstline. Project Firstline was an initiative to provide immediate infection control education in the height of COVID. Since then, it's evolved to provide any general infection control education to frontline healthcare workers. Next slide. I am Jess Stanko. I'm a program director at the South Dakota Foundation for Medical Care. Also with me on the team is we have 4 other members. You may see some new faces here, so I want to allow an opportunity for each of them to introduce themselves so you can get familiar with our team and everybody that's working on the Project Firstline initiative. Rebecca, do you want to kick it off?
Yeah, I am Rebecca Syme. I am the Project Firstline team lead. I'm a registered nurse and also hold a certification in the long-term care with CIBIC. And I will let the other girls introduce themselves.
And I'm Valerie Wagner, and I am a registered nurse as well. And I am a part-time PFL team member.
Renee, you're on mute.
Okay. Sorry about that. Renee Robbins, I'm a registered respiratory therapist and registered pulmonary function technologist with a bachelor's in health sciences, emphasis on public health, and I am a part-time Project Firstline team member as well.
Hello, everybody. I'm Jamie Rogenbauer. I'm also a part-time team member for Project Firstline. I have got a master's in public health, and I've been an EMT for 14 years.
Fantastic. Thank you, everybody. We have some exciting new things happening for the South Dakota Project Firstline team. You'll be seeing many changes come out in the coming weeks and months, so be looking for that. And as always, we'll continue with our office hours. That happens monthly and is recorded and available on our website for sharing after the session. So I will go ahead and let Rebecca go to the next slide, and Val can take it from there.
So today's topic is measles. And what we want you to learn from today with the objectives is we'll review the disease. We're going to share up-to-date facts on measles. We are going to discuss the process of containment in suspected cases to prevent the spread of measles and discuss infection prevention to prevent the spread of measles. Next slide, please. So let's define it. What is measles? Measles is one of the most contagious diseases ever known and is an important cause of death and disability among young children worldwide. The measles virus will infect anyone who's not protected. Next slide. So a little background. Measles can cause severe complications in children and adults. Some people may suffer from severe complications such as pneumonia, the infection of the lungs, and encephalitis, which is swelling of the brain. They may need to be hospitalized and could die from the disease. Next slide. Hospitalization occurs about 1 in 5 unvaccinated people in the US who get measles. And pneumonia, as many as 1 out of every 20 children with measles gets pneumonia, the most common cause of death from measles in young children. Encephalitis, a little bit about that, about one child out of every 1,000 who get measles will develop encephalitis, or that swelling of the brain. And that can lead to convulsions and can leave the child deaf or with intellectual disability. 1 to 3 out of every 1,000 children who become infected with measles will die from respiratory complications or neurologic complications. Women who are pregnant are also at a high risk. So measles may cause pregnant women who have not had the MMR vaccine to give birth prematurely or have a low birth weight baby. So who is at risk for measles complications? Measles can be serious in all age groups. However, there are several groups that are more likely to suffer from measles complications. Like we said before, the pregnant women, the children younger than 5 years of age, adults older than 20 years of age, and people with compromised immune systems, such as from leukemia or HIV infection. Excuse me. Before the measles vaccination program started in 1963, an estimated 3 to 4 million people got measles each year in the United States. And of these, 500,000 cases were reported each year to CDC. Of these, 400 to 500 died, 48,000 were hospitalized, and 1,000 developed encephalitis from measles. Since then, widespread use of measles vaccine has led to a greater than 99% reduction in measles cases compared to the pre-vaccine era. So why this is important now? There is a decline in measles vaccination rates globally, and that has increased the risk of outbreaks. Measles cases continue to be brought into the USA by travelers infected while in other countries. Most importations come from unvaccinated US residents. When measles gets into communities of unvaccinated people in the US, outbreaks can occur. In recent years, measles importations have come from frequently visited countries, including, but not limited to, the Philippines, Ukraine, Israel, Thailand, Vietnam, England, France, Germany, and India, where large outbreaks were reported. So what CDC does when the measles outbreaks occur. So the state and local health departments have the lead in investigating the measles cases and outbreaks when they occur. Their job is to determine who may have been exposed and is at risk for measles because they have not been vaccinated or are not otherwise immune. A lot of that contact tracing you could probably relate to. CDC helps and supports health departments in these investigations by epidemiology, laboratory, communications, and travel. So let's think measles. When you're seeing people in facilities or establishments, consider measles in any patient presenting with a febrile rash illness, especially if they're unvaccinated for measles, or traveled internationally in the last 21 days. Incubation period is typically 11 to 12 days from exposure to measles virus until the first symptoms appear. A rash follows the prodromal symptoms 2 to 4 days later and usually will last 5 to 6 days. Measles is infectious 4 days before and 4 days after rash onset. The picture here, supplied from the CDC, gives a couple examples of a rash, the maculopapular rash that is associated with measles. Other symptoms include high fever, cough, runny nose, conjunctivitis, which is also red or watery eyes. So on the rash, it typically appears 2 to 4 days after symptoms begin. It begins at the hairline and spreads downward to the face, neck, and trunk. The rash appears red on light complexions, but may be harder to see and appear as purple or darker than the surrounding skin on dark complexions. Next slide. For those reporting measles symptoms, assess the risk of exposure. Are measles cases present in the community? Did the patient spend time out of the country in the 21 days before symptoms onset? And have they received their MMR vaccination? Triage these patients, and it should be triaged through a clinically trained person. If the person will be seen in an office setting, provide instructions on face mask for the patient. If it is a 2 years of age or older child and the family members present. Instruct to arrive to the side or back entrance instead of the main entrance. We want to maintain exposure. Patients presenting with suspected measles, provide face masks to patients, again, with the 2 years of age and older, and family before they enter the facility. Patients unable to wear a mask should be tented with a blanket or a towel when entering the facility. Immediately move the patient and family to an isolated location, ideally an airborne infection isolation room if it's available. If unavailable, use a private room with the door closed. No other children should accompany a child with suspected measles. Patients that are 2 years of age and older and the family should leave face masks on if feasible. Next slide, please. Infection prevention precautions. Only healthcare providers with immunity to measles should provide care to the patient and family. Standard and airborne precautions should be followed, including the use of a fit-tested NIOSH approved N95 or higher level respirator, use of additional PPE if needed for tasks such as the gloves for blood draws, cleaning hands before and after seeing the patient, limiting transport or movement of the patients outside of the room unless medically necessary. Next slide. So public health notification. To ensure rapid investigation and testing with contact tracing, notification should occur immediately upon suspicion of measles. Public health departments will be able to confirm vaccination history for U.S. residents, provide guidance on specimen collection and submission, and manage contacts of confirmed cases. Acute care facilities should immediately notify the hospital epidemiologist or infection prevention department. Outpatient settings should immediately notify local or state health departments. In the clinical care setting, people with confirmed measles should isolate for 4 days after they develop a rash. If an AAIR was not used, the room should remain vacant for the appropriate time up to 2 hours after the patient leaves the room. Standard cleaning and disinfection procedures are adequate for measles virus environmental control. Some additional actions for healthcare professionals. Ensure all patients are up to date on MMR vaccination. Adults who have presumptive evidence of immunity include a birth date before 1957, a laboratory evidence of immunity, prior laboratory confirmed measles diagnosis. Adults with evidence of immunity generally should get 1 dose of MMR. 2 doses are required and recommended for high-risk adults, such as the healthcare personnel, international travelers, and post-secondary school students. Now we're going to open it up for any questions or comments for the team.
Thank you, Val. That was great information. Now is the opportunity in our office hours to ask any questions, as Val had said. It does not necessarily have to evolve around the topic of today, which was measles, and really provided some great information for the healthcare personnel and setting. But the questions can be centered around any infection control topics for Project Firstline. Does anybody have any questions?
I was curious, the places where the importations come from that were listed. So there's more outbreaks in those countries. Is that due to lack of vaccination rates? What's the reasoning behind that?
From what my understanding is that's where the outbreaks because of not vaccination status.
You know, I find it very interesting. Rebecca and I were guest speakers at a national conference and traveled to a city within the United States. We were out to dinner and we were really wondering, why is everybody wearing masks? Actually, a city in the United States recently had an outbreak in May. And so many of their food service people and those type of individuals were wearing masks while they were working. So it definitely is in the United States, and these outbreak areas are happening because of the lack of vaccinations.
My mind kind of wants to, the curiosity is there anyone with us today that has seen an individual with active measles outbreak? Has anyone? I haven't. I know I personally have not, but we, like Jess said, we know it's out there, obviously. But
Are there specific communities where you see, is there a common factor between communities where you see the outbreaks, like just with the vaccine hesitancy? Is it religious? You know, I guess, what do you see when you look at that? Have you looked into it any deeper than this, or?
I have not dove deeper into that. I know a lot of communications have noted an increase in vaccine hesitancy, but I did not research that piece of it for this.
The other thing to think about, like in our communities or cities in the United States, this one in particular really was a hub for international travel. So maybe one of those layover airport areas, those type of things, that where the outbreak happened. So
for sure.
So it's a global health issue, but it's not, so it's worse in other countries, but we still do have outbreaks in the United States.
Mhm.
absolutely.
Isn't that crazy when there's vaccine available that it's still ongoing? Just
A lot of
amazes me.
yes, ongoing need for education and re-education and not forgetting to talk about it. Absolutely. So
Awesome.
any other questions from anybody on the call? All right, I think we have one more slide on here.
I gotta pop back over there. Sorry, give me just a second.
That's okay. On here is a QR code. If you could complete it for us, there is an opportunity to provide any future topics that you would like us to cover. We are always welcome and open to suggestions. You absolutely can reach out to any of us through email or through the SD Project Firstline website also. If you're looking for trainings, either specific for your facility or a general topic, we can provide those. Or offer you resources, materials, any type of item like that.
I'll also add to that, you see today we have a bunch of new faces and change is happening for us. And we have a very varied background with all of our new team members. So this is a great opportunity for you, like Jess said, give us those ideas of things you want us to see, infection prevention, training, education issues. Let us know if there's something we can bring forward for you and give presentation on. We'd love your input on that so we can get you what it is that's important and relevant to you for sure. We're all here to help.
All right, if there's no other questions, we will go ahead and wrap up our office hours call today for June. We will be back next month with another exciting infection control topic. It may even be one from your guys' suggestions. So thank you very, very much again for taking the time to join us. We hope you found this helpful, and we look forward to next month.
Thank you, everyone.
Thank you.